Welcome to Lab 2, and you're going to learn about the anatomy of the heart, about pulse, and your blood pressure. So here are the questions from your lab manual, but remember, these have been converted to multiple choice questions, and they're over in your assignment tab, so when you click on each week, there'll be a pre-lab, and that's what this is. These are the pre-lab questions. So there have been some people wondering where the pre-lab questions were. If you're absolutely stumped and can't find them, you can always just send me the answer by email for these 5 questions, and then I can grade it and put it in Blackboard for you. But the multiple choice is easier, and it immediately puts your grade over into Blackboard. I'm pretty sure I have most of you for both lecture and for lab. So you should have seen a lot of this information in the video that I made for you. If you are in my lab but you have someone else for a lecture, I'm happy to send you the video so you can watch over it, because I spend quite a bit of time going over bit by bit. So the thing that drives me crazy, even with this lab manual and your textbook, is that they don't tell how the blood flows through the heart the way I think makes sense. They act like it is a circle like this, and so it flows in from the inferior and superior vena cava into the right atrium over the tricuspid, which drops it down into the ventricle, and then from there it's pumped over to the pulmonary side, through the pulmonary valve, goes through the trunk, branches off to the arteries, goes to the lung, comes back to the veins, through the veins to the left atrium, goes through the bicuspid valve, drops it down into the left ventricle, and then it's pushed through the aortic valve, through the aorta, and out to the body, and then back to the superior vena cava. And that is not what is happening. The heart has 2 halves, and so while it is draining into the superior and inferior vena cava into the right atrium, you have blood coming in from the pulmonary veins to the left atrium. At the same time, the left atrium and the right atrium are filling up. It drops through the valve into the ventricle, so the left dumps into the left, the right dumps into the right, and then the heart beats, and blood is simultaneously pushed from the right ventricle over to the lungs, and from the left ventricle out through the aorta to the rest of the body. These are happening simultaneously. But the way these charts look, it looks like that the blood is going around and around in the heart. And so many students get confused by that. So anyway, this is in your lab manual. I just explained it to you, but that's not actually what's really, really happening. So there you have it. But the questions you'll have on the quizzes and the exams are things like, what is the name of the valve between the right atrium and the left ventricle? Or excuse me, the right atrium and the right ventricle. Or how does blood leave the right ventricle? What vessel does it go through on its way to reach the lungs? And you talk about the trunk and the arteries. So it'll be broken down in pieces, but I just find this to be wrong. Here's another thing that kind of bums me out, and if I was the king of the world or the queen of the world, that I would change the name a little bit. But most of you, when you think of the base of something, like the base of a mountain or the base of something, it's the bottom. But in the heart, the base is the top. That's where the atria are. And the bottom, which is the little pointy part that points over to the left, is called the apex. And most of us think of the word apex as being the top of something, but apex actually means the pointy part. So apex I can sort of see, but calling the top the base is just confusing as heck. one of your objectives is to be able to identify normal heart tissue and also diseased heart tissue. Now, we're really not looking at diseased heart tissue because, well, if you had diseased heart tissue, a lot of times it's been replaced by scar tissue if you survive long enough. But if you don't survive, then you're just going to see an area of tissue that has died. So be able to identify normal heart tissue. You need to be able to find intercalated disc, and you need to see the striations so that you know that it is a striated muscle as opposed to a smooth muscle. But intercalated disc are the number one thing that you really, really want to be able to see in a normal heart tissue. The blood flow through the heart, we just went over that. It happens on the left side simultaneously with the right side. And master pulse pressure measurements. If you want to see someone's pulse, you can either reach over, come up from their thumb above their wrist, and hit the radial artery. That's where almost everybody does the pulse. And they put their first 2 fingers on it. You have a pulse in your own thumb. So if you try to put your thumb on that artery, then the pulse of your artery is going to be pressing against the artery of the person whose blood pressure you're trying to do, and you're going to get a confused reading. So you use your first 2 fingers and you put it down on the radial artery. Now, you also can reach up on the neck and do the carotid artery. So some people do that. All right, so those are the main places that you check for blood pressure, but almost everybody does a radial pulse up from the thumb of the person who you're doing the pulse for. Chambers of the heart, that's easy. There are 4. There's a left and right atrium and the left and right ventricle. So, I mean, there's just that. You might think about the little auricles that are little flaps, little ear-like flaps that are sticking out on the side of the each atrium. The valves of the heart, there's 4 of them. There's one between the atrium and the ventricle on both sides, and then you have to leave the heart, so the one that goes through the pulmonary to the lungs goes through the pulmonary valve, and the one that goes to the aorta goes through the aortic valve. So that's pretty easy to get the 4 valves and the 4 chambers. Hopefully nobody will mess that one up. Additional structures, you have the whole cardiac coronary blood system that nourishes the myocardium. It nourishes the muscle of the heart. So we're going to learn the names of some of the cardiac vessels, and then of course the vessels that leave the heart and come back to the heart. So that's our goal. Those are our objectives for what we're going to be doing. One of the main things that you're doing is you're getting oxygen to the lungs, from the lungs, back to the heart, and throughout the body. So that's kind of one of the main things. But now the heart does other things than that, but you'll learn about that in lecture. You need to know that there is a double-layered serous. That's not serious. Like, are you serious about this? It is serous membrane, and that means that it secretes a fluid. And this is good because as your heart is beating, it causes friction. And you don't really think about it, but think about the piston in your car. If you don't have lubricant, if you don't have oil, then that piston's going to freeze up. You're going to have too much friction, it's going to get too hot, and it'll seize up, and then your engine won't work anymore. So you do need fluid to kind of reduce the friction of the heart beating. So that's the serous membrane, double layered. The one that touches the heart itself, the most innermost layer, is called Visceral Pericardium. And outside you have the parietal. All of this fits into the pericardial cavity. So you got a whole bunch of P stuff going on. You got pericardial, parietal pericardium, and let's see, it seems like there was another P word in there too. But anyway, so work on those. Think about, okay, which one's which layer's what. But the easiest one, of course, is the one that is the inner layer. I do want to point out one more thing before we leave this page. Of the flaps, or the valves, that regulate the flow through the heart, 3 of them have 3 flaps each. So the ones that are exiting, which are the pulmonary and the aortic, have 3 flaps. And of course the tricuspid has 3 flaps, or cusps. So the only one that has 2 is the mitral, or the bicuspid, and it's on the left side. It's on the left side. So just pay attention to that. Pretty much everyone has listened through a stethoscope and heard a heartbeat, or you hear it on TV, or maybe you've had a baby and you listen to the baby's heartbeat, and that is so exciting to listen to that. So you hear a lub-dub, lub-dub, lub-dub sound. You need to know what's happening with the lub and what's happening with the dub. So when you hear the lub sound, the very first sound, that is the ventricular systole, which is basically a fancy way of saying the ventricle contracted. So that's the first sound. And the dub sound is the beginning of the relaxation. And the semilunar valves close. So that's the dub. So make sure you know what the lub is and what the dub is. And if you're young, sometimes you have 3 sounds. And if you have a hole in your heart, in the septum that divides the left and right half of your heart, then you can actually hear the blood squirt through the hole every time that the heart beats. So that's called a heart murmur. And then sometimes you have an incompetent cusp or flap. So something's happened, it has bacteria growing on it, it's calcified and has become hard so it can't move. You may have been born missing one of the flaps. That happens from time to time. It's not that uncommon. So anytime you have any of these situations, along with the lub-dub, you're going to be hearing a squirting sound. And depending on what the squirting sound sounds like, you can sometimes tell which of the valves is messed up, or whether or not it's a hole in between the left and right sides of the heart, and it's going through the septum that's in the middle. So if I know that if it's leaving through an aortic valve, that something's wrong with it, it squeaks as if you are rubbing a balloon. So it has a characteristic squeaking sound. The last page of your lab has a list of all the different things you're supposed to learn in this chapter. So it's a nice little checklist to say, do I know where the chordae tendineae are? Yeah. Another name for chordae tendineae are heartstrings. And they are anchored on the papillary muscle. Looks like a nipple sticking up there. And on the flaps of the tricuspid and the bicuspid. So you actually do have heartstrings. So when somebody says, oh, you're pulling on my heartstrings, you actually have some. And the reason that you have them is to anchor the flaps so that when the ventricles contract, so here's the ventricle squeezing, and it's pushing the blood. You don't want the blood to go back up in the atria. You do not want that to happen. So when you squeeze this one, you want it to leave and go through this flap. And when you squeeze this one, you want it to go, you can't, let's see, it's like through that flap. So you're going to have to go over there and do it. So that's the object of the game. So these are held down so that they can't fly inside out when the blood pushes up against them. And then they relax, the blood flows back down, and then you contract again. So chordae tendineae, everyone should know cord, made of tendinous, like, the tendons and ligaments. So chordae tendineae, papillary muscle, nipple-shaped, there's one, and that's what the heartstrings are attached to. Here's the interventricular septum. So it is the septum that divides the left and the right ventricles. And it is continuous, although you can't see it here, but it's continuous and goes up and also separates the left and right atrium. But if it is down here, we say it's the interventricular septum, and up here where it's separating the left and right side of the atria, it's called the interatrial septum. So it's still the same septum, but because it's upper and lower, they give it two different names. All right, we talked about the valves. You guys should be totally cool with the valves. You can always tell which side of the heart's which for a variety of reasons. If it is in the body, you can tell because it is pointing to the left. So that's the left side because it is pointing to the left. But the other thing that's a dead giveaway is, well, you can count the flaps, because the left side has 2 flaps and the right side has 3 flaps for the valve, tricuspid versus bicuspid. But you can also look at the wall. The outer wall right here is way, way thicker than this one. And the reason for that is because when you're squeezing the heart and you're squeezing the blood, this has to contract hard enough and push out through the aorta and make it through the whole body. So that takes a lot of pressure to get it to go all the way through the whole body. Now the right side only has to push far enough to get to the lungs, which are literally sitting right next to it. So it does not have very far to go, and so you don't want to slam the blood out of this side and then go out through this and branch off to the lungs with too much pressure. So in order to regulate that, because they're both going to beat at the same time, and they're both going to get the same electrical energy coming down through the septum. So having this one thicker, you're going to be able to push the blood farther and harder. So be aware that the left side is way thicker than the right side. So even if this had been cut out to where you couldn't see the aortic arch and you couldn't see the pulmonary trunk branching off into the arteries, you still could just look at the wall and say, aha. So there's a number of cues that'll tell you whether it's the left or right. So I just gave you a whole mess of them. Now the muscle right there is called, and this right here, keep going on there, is myocardium. Myo means muscle and cardium means heart. So it's your heart muscle. So it tells you, if you read Latin, exactly what you're looking at. And let's see, the pulmonary trunk we went over, the left pulmonary artery. Well, obviously this is the left side of the heart, so that's the left pulmonary artery. And this is going to go over to the left lung. And there's the right pulmonary artery, and it's going to go over to the right lung. So that's kind of obvious. Now, interestingly enough, not everybody's plumbed the same way. So that's kind of interesting. But most people are plumbed this way so that you have branchings off of the aortic arch. Here's the aortic arch. And they go up to the brain and then branch off and come down. So some of them are going up to the brain and some of them are going up and then curving back down. But the majority of the blood is going to continue on past the aortic arch and on down And it actually runs behind the heart, kind of in front of the vertebral column where your vertebrae are. So that's kind of interesting. So you have some protection back there. All right, is there anything we didn't cover over here? I think we hit every last thing. Ascending aorta, okay, aortic arch. And then there's the inferior vena cava coming in and dumping. And there's the superior vena cava. So the vena means vein, means this is not an artery. So you're thinking, man, that's big, that's an artery. No, it's not. Coming into the heart, you have veins. Coming away from the heart, you have arteries. Arteries away, arteries away. Incoming are veins. So whatever it takes for you to remember that. All right, cool. We got everything on that picture. So that last picture was kind of like a coronal cut through the heart so that you could open it up and see on the inside what's going on. So now we're looking at the outside of the heart. So we've not cut it open, but we still know the left side, even though we can't see which is the thicker side. And we can tell because of the way it points. It's pointing over that way. And now we can see those coronary arteries that I was talking about and coronary veins. So because the heart is just a big old muscle, it's got blood inside of it, but that blood is not going to be able to penetrate all the way through the lining of the heart and all the way through the myocardium, the muscle of the heart, and nourish the whole heart. So what you're going to have to do is you're actually going to have blood vessels on the outside of the heart that go into the heart, into the muscular wall, and nourish it. So you're nourishing it from the inside, but you have to nourish it from the outside. And most people who die, it's because these things get clogged up. Something clogs up one of your coronary arteries, and everything from that point down dies because you can't get the blood through and nourish that part of the heart. And heart muscle doesn't last very long unless it's got a steady flow of oxygen. So what they'll do is if your coronary arteries and some of your larger vessels are blocked, they will go in and cut the area that's blocked out, and they'll sew in another vessel from your body. A lot of times they go down in the leg and they get one of the big veins down there, and they bring it up and they sew part of that vein up here and down here, and it bypasses the blocked area. So when they talk about somebody having a bypass operation, that's what they're doing. They're bypassing a blocked area of these coronary vessels. So sometimes you have a quadruple bypass. Wow, you got stuff blocking 4 of your major vessels. So if they can bypass and renew the blood flow, to go past the blockage, then you're going to be fine. But you need to catch it. So a lot of people will be experiencing chest pain because if you've got blockage, your heart is actually going to be sending out a message to you that, hey, I'm dying. This hurts. I'll send you out a message so that you can go to the doctor and say, I've been having some chest pain. And then they need to look and see if you have blockage. So you can prevent a lot of heart attacks by going in and listening to your heart talking to you when it's telling you that, hey, something's not right here. So you can usually feel it. It just sneaks up on you and one day you just have a heart attack, bam. That's what they do in books and things like that, but that's generally not the way it happens. Unless, of course, you've got like a huge embolism. Now, if you get a huge blood clot, then yeah, you can suddenly stop blood flow to the heart, and it'll start dying quickly. But generally, you just kind of fill it up with fat, and it just gets more filled up, and you have less and less space for the blood to go through. So you've got some major ones that are going in the groove between the ventricles, which is the big part of the heart, and the atria, which are the smaller parts of the heart. And then you have some that run straight down, and as you see, they're branching off as you go through. And you have some on the front, and you have some on the back. So we learned, hopefully somewhere, that when you see the word anterior, it means in the front. And if I were to flip this heart over, there would be a posterior. So this particular artery is called the anterior interventricular artery. So you remember when we talked about the septum that separates the left and the right side? Well, running along on the outside of the heart, there is this interventricular artery, and this is in the front. So if you're looking at the person, it would be in the front. To help you guys out, they have colored the veins in blue and the arteries in red. Obviously, in your body, they're not colored, but that'll kind of help you a little bit there. Now, this is nice. On the right side, here's the right side, this is called the right coronary artery. That's kind of cool, right coronary artery. And it runs along, there's the right ventricle here, and the right atria there. We already know the ascending aorta, the superior vena cava. The inferior vena cava is not labeled, but it's the one down here because inferior, superior. And here are those three things that we saw branching out. Well, now we're actually going to put a name to each one of those. So this is the Brachiocephalic Artery. So the brachial region is your upper arm. So this is going to be coming up and then going down to your upper arm. And the cephalic region is your brain. So this one's going to go up to the brain and then also down to the arm. Brachiocephalic. The left common carotid artery and the left subclavian artery. So this one's kind of got a weird path, the way it goes. So if you reach up on your, below your neck, so on either side of your neck, you have the clavicle, and it's a bone that runs, trying to think about, if you come to the base of the neck, it comes right out there and goes towards the top of your arm. So that's where your clavicle is. So the subclavian means it's going to go below the clavicle. So this is the left subclavian artery. So just think, clavicle. Okay, I know where that one's going. So three of them right there. Brachiocephalic. It's the first one coming off the arch. Left common carotid. Left subclavian artery. The aortic arch, and then the descending. So we have ascending, arch, and descending. This is all just the aorta. It's just three names for the same tube. We're going to do the same thing with your intestines. With your large intestines, we're going to have your ascending and your transverse and your descending intestines. So we do that a lot, so you know exactly where you are. The pulmonary trunk, you guys are cool with, and you know the left pulmonary artery is going to be coming off the left side where the left ventricle is. And your left coronary artery, right there. Okay, left coronary artery. Okay, circumflex artery. Circumflex. How are you going to remember that one? I don't know. If you know about circumference, you know it kind of goes in a circle. So I'm thinking that this has something to do with the fact that it comes around like that. All right. So I can't help you memorize this. I can give you little helpful hints that might make it stick in your head, but ultimately you guys just have to sit down with these pictures and make sure that if you cover up these words, can you tell me what this is? Without the words, can you tell me what this is? What's going on here? What are these things? What's this thing? What is this one that runs down here? What's that one that runs down there? So I'm just going over giving you some things to help it stick in my mind, but ultimately you're the one and you got to memorize all this stuff. So there. So if you're looking over this list of things, everything you're learning the name of are the arteries, the major arteries, coronary, left and right coronary arteries. But there's one vein. It's the great cardiac vein. So there's many, many veins, but this is the only one you've got to come up with a name for. So those of you who have me for lecture also, you've seen this before. This is where they've taken a human heart, they've injected the veins with blue latex, and it's in a liquid form like Elmer's glue kind of liquid, and they squirt it in the veins. And then they take red latex and they squirt it in the arteries. And then they put something that digests meat, because your heart is muscle, it's meat, and you can just digest it away, but it won't dissolve the latex, it won't dissolve the rubber. And so this is what it looks like if you've eaten the meat away and all you're seeing are the arteries and the veins that are nourishing your heart. So these are the coronary arteries and coronary veins. And as you see, there's way too many for us to name them all. So they just picked a handful of the more important ones, the ones that are often occluded or blocked and have to be replaced. But you can imagine what kind of a headache it would be to try to memorize all of these veins and arteries. So wrapping it up, here is the checklist to see if you remember everything. The right atrium, the left atrium, the right ventricle, and left ventricle. So there's the 4 chambers of the heart. Here are the 4 valves. The pulmonary and the aortic are the easy ones to remember. And you just have to remember that the right and left are both AV, or atrioventricular valves. But to differentiate quickly, so you don't have to say the right atrioventricular valve, you can just say the tricuspid. And everybody goes, oh, that's the one on the right side. Or the left atrioventricular valve, they just say, oh, that's the bicuspid or the mitral valve. So bicuspid, mitral, and left AV are all the same word. They're all describing the same thing. So sometimes you'll see it called one thing and sometimes another. The extra or other structures, they want you to know about the septum that divides the left and right side. They want you to know that the majority of the heart is myocardium. So there's the outer covering, the pericardium, and then there's the inner lining, which is endothelial tissue. We'll learn a little bit more about that too. All right, and there's a list of all the blood vessels that they want you to be able to identify. So on your quizzes or on your exam, you can have a picture of the heart and they can have a little arrow and go, what's that? What's that? What's that? So go through this and see. Now, we didn't talk about the coronary sinus, so we should probably back up and go find that one, because that's kind of important to find that one. We did look at the anterior interventricular artery. We didn't see the posterior one because they didn't flip it over for us to see the back, but then that's not one of the things you had to learn anyway, but you should be aware that there is one. Left subclavian artery, left common carotid artery. So these are the 3 as they come off of the aortic arch in this order. So remember those in that order, and that'll help you. The circumflex artery, that was the one that was like, well, I don't know, it kind of goes around over there, kind of meh. So that might help you with that one. So let's go back and see if we can find the coronary sinus, because that's important. Well, they don't have a picture of it. Well, that stinks. I'll go find one. All right, interestingly enough, in the lab manual, they have 2 pictures of the anterior surface of the heart, but they don't have any pictures of the back of the heart or the posterior view. But if you went and flipped it over and looked at the posterior view, you'll see this place. It's kind of a widening area right there. And so a lot of the blood that needs to be recirculated will flow into there, and then from there it can flow on into the atria, and it can go back and be oxygenated. So when I was talking about it in lecture, I said it's kind of like the rectum. It's like the holding chamber. So all the poop in your body goes and finally ends up in your rectum, and it fills up the rectum, and then the rectum empties out, and you have a bowel movement. So it's kind of like the rectum or the holding chamber. So a sinus is a large hollow area. So you have sinuses in your nose. So we're going to see the word sinus more often. You have sinuses in your brain, like holes in your brain. See, you have holes in your brain. Your mother was right. Here's a little bit better picture. I kind of like this one a little bit better. See how much bigger that is? Right there. So everything can drain into it. Now, when we have face-to-face lab, where you guys actually come in and we don't have to worry about COVID, then we actually have microscopes set up, and you would look at this cardiac tissue underneath the microscope. But since we are doing this online, it's important for you guys to be able to identify cardiac muscle. And this is normal cardiac muscle. So you've got these fibers, and if you look really closely, they're striped. There are stripes on it. So it is striated muscle. But what gives it away that this is not skeletal muscle, this is cardiac muscle, are these intercalated discs. Here's how you spell it, intercalated disc. So there's one right there, there's one right there, here's one over here. Man, they got such big green arrows, they're kind of almost covering them up. There's one right there. So what the intercalated discs do is they join each of the heart muscle fibers together. So if you look, it's kind of bundling this up, and then some of this branches off and bundles off with that one, and it goes off to this one. And if you look, so when a message goes through, an electrical message goes through and says, all right, it's time to beat, we need every muscle fiber to contract. Then the message can go through these intercalated discs, because there's actually gap junctions in there, holes that allow the messages to go right from here through right there, over there. And so everybody gets the message at the same time, and all the muscle fibers of the atria, the left and right atria, contract. And then the signal goes down to the atrioventricular node and down through the interventricular septum, and it goes up the walls of the left and right side, and every muscle fiber in the ventricle then contracts. So the atria contracts separately from the ventricles, and what stops them is it has to make it through the AV node, and then down through the bundles, they're called bundles of His, that are in that septum, and then at the ends it kind of frays off and comes on up the outer walls, and they call them Purkinje fibers. So we didn't have that as one of the things that you needed to learn, but you do need to learn it for lectures, so I'm going to go ahead and talk about it a little bit here. So what you'll see on the exam is probably a slide that looks like this, and as soon as you see those intercalated discs, you go, oh, that's cardiac muscle. That's myocardium, or heart muscle. So that's the giveaway. This is a cartoon picture, an artist's drawing rather than an obvious real artery. But you get fatty deposits along the wall, and if the fatty deposits are on both sides, like cars parking on both sides of the road, and you can't get through. And all you need is just one little something getting stuck there, and then this whole thing is blocked off, and no more blood can flow through. So now you have a blocked artery. So we have some slides showing real arteries, and you can see the plaque. You can see this fatty buildup on the wall of it. And then on some of them, you can actually see where the tissue around is dying. It's dead because you can't get blood flow through and you can't get oxygen to the tissue, and so it dies. So that was one of the slides that we had if we were doing face-to-face. All right, this is actually a clogged artery. This is the real deal. They've cut this out of a person. Obviously, this person's dead. And there's the artery right there. And you can see the buildup right here. But, there's a huge buildup right there. So not so much blood can go through. It's blocking this artery. So it's partially obstructed by plaque. And plaque is spelled Plaque. So looking at this picture, you guys should be able to tell this is the left side, and this is the right side. And then there's the septum that separates the left and the right side, and that is a heart attack. That is a myocardial infarction, and that is dead tissue right there. So obviously, because we're looking at this picture, this person's dead. So this is an autopsy picture and showing you a myocardial infarction, or an MI. All right, the next page of things that you're supposed to be doing in this lab is they want you to watch a video. So there's a YouTube video. So just type that in and look and see. It'll talk about the heart rate, the sounds that you have, auscultation, where you're listening to the different sounds. And one of the things that I wish desperately that you guys were with me in person so that we could learn how to take a blood pressure correctly, because it's really funny. I mean, I teach this for a living, and then I go to the doctor and they put the blood pressure cuff on upside down, or they put it on backwards, and they pump it up, and I'm just looking at them going, there's no way in this world you're getting a blood pressure reading. And they'll just look at me and they'll go, it looks like it's 125/75. Is that what you think it is? And I'm like, yeah, that's what I think it is. Not because I have high blood pressure. But since they don't know how to work a blood pressure cuff, and it always worries me. So sometimes if I'm having one of my Karen moments, then I will say, here, let me show you how to do that. And I'll show them how to put it on correctly. So the name of the blood pressure cuff is are you ready for this? Sphygmomanometer. So the PH sounds like an S. So that's an SF sound, sphygmomanometer. And you need a stethoscope, or now we have digital things that can listen and record the pulse. And you can listen to the heartbeat with a digital meter, so you don't have to actually have the stethoscope. But the stethoscope is that thing that the doctors always wear around their neck, and then they pull it off and they put the two little things in their ears, and then it has a little membrane at the bottom, and they put it on your heart and they listen to you breathing. So you need the stethoscope because you need to listen to the heart sounds anyway with a stethoscope. But to take the blood pressure, you can use a blood pressure cuff that has the built-in digital thing, and you don't actually have to have a stethoscope. All right, and it tells you just what I told you. You take the pulse using your index and middle finger. Do not use your thumb. Come down the thumb of the person whose wrist or whose pulse you're going to take. Come down their thumb and come past their wrist, and you'll feel the radial artery. There you go. Do not use your thumb. All right, and you can sit there and count how many beats it is for a whole minute, or you can count how many beats there are for 30 seconds and multiply by 2, or you can count how many beats there are for 15 seconds and multiply by 4. So it just depends on how busy you are and how fast you want to take the pulse rate. Of course, a lot of those cuffs that they use now, the digital cuffs, they'll give you the pulse as well as the blood pressure. So it gives you both of that. So let's see. Here's an old-timey blood pressure cuff. And this one actually, when you pump it up, you're actually pumping up mercury. You can actually see the mercury pumping up this tube right here. And so you can watch the mercury bouncing around inside the tube to figure out the blood pressure. So that's one of the really older ones. Now, this one, you have to stare at it for a minute, but this one is actually put on correctly. So the object of the game is to put the cuff on above the elbow. And this one, this tube right here that's connected to the machine, now he shouldn't have his hand resting on it or his arm resting on it, so that's incorrect. He needs to have the machine over so he's not putting a crimp in the tube. So that was kind of silly right there. What I do whenever I'm putting on a blood pressure cuff, I take this right here, this tube, and I hook it on the person's thumb. So it's running the length of their arm, coming down here, and coming right there. And I know for a fact that I'm over the radial artery. So you need this to be lined up with the radial artery. So it is positioned correctly, because if you follow this down, it would line up correctly. But it's not put on correctly because he's not supposed to have his arm there. The other thing is, you don't want the person, so he's obviously having to use his hand on the table to lift off so that he doesn't have his arm on this thing back here. And you don't want the patient contracting their arm anywhere. So this arm has to be completely limp. And it needs to be, hopefully, not hanging straight down. You need to have it resting on a table or something. So this, they put the cuff on right, but this is in the wrong place right there. It's interesting, once you know how you're supposed to put it on and you start trying to find a picture on, well, I'm trying to find on Yahoo, but instead I'm getting it on Bing. But, so this one's put on wrong. Look where that is. That's not where the arteries are, right there. So this person's putting the cuff on incorrectly. All right, you should be sitting down and relaxed, not standing up. You should have your feet comfortably on the floor. You don't want to be having to contract your legs. You don't want to be swinging your legs. You don't want to cross your legs. You just want to sit with both feet on the floor. You want the cuff heart level. Relax your hand. Just have it laying limp on the table. And you should be sitting upright, not slouched over. Your back should be fairly straight. So this is the proper way to sit. And if you can remember to take that tube and run it along your thumb, you're good to go. I don't even know what to say about this one. Clearly, here's the person's thumb, and there's no tube there. So I don't know what's going on. But if you're going to be listening using a stethoscope rather than using a digital, then you want to put the head or the membrane of the stethoscope right in the antecubital region, the inner elbow region right there. And you may have this person's pushing down. If you tuck it in under the cuff, it'll kind of hold it in place. And what you're listening for when you take the person's blood pressure is you want the first heart sound. So when you pump this up, what you are doing literally is shutting the blood flow off to the arm. You literally are shutting it off. And it kind of hurts, if you pump it really far up. And then you slowly release the pressure. So you can't really see right there, but she's got a little knob in her hand and she's got that bulb in her hand. So she's already pumped it up. And now she's releasing the pressure slowly with this little valve that she's turning right there. And you can also watch on this gauge. There's a needle on here that's going around from 200, 180, 160, like that, coming around the dial. So you can listen with your ears and hear as soon as there's enough pressure in your arm to bypass this thing. So at first it's too tight and you don't get any blood flow, but the blood's sitting there waiting to come through, and as soon as the pressure comes off enough to allow the blood to come through, so the pressure in the cuff equals the pressure in your arm, that's your first reading. And you'll actually suddenly start hearing the heartbeat. So when it's closed off, you're not hearing anything because the blood can't get through. But as soon as the blood starts coming through, you'll hear it going thump, thump, thump. As it comes through, as the heart is beating, you'll actually hear the surging in the arteries. Then, as the pressure becomes so little, the sounds will die away. And that's your lower reading. So that's how much pressure there is in your blood vessels when they are relaxed. So that's your lower reading. That's usually the one that people pay the most attention to when they're determining whether or not you have high blood pressure. Because if it doesn't relax to where you don't hear the blood pounding at between, say, 85 and 75, you've got high blood pressure. So you have so much pressure still in your arteries that it can cause your arteries to pop. It weakens your arteries. You have too much pressure. But we've ascertained, somebody decided, that if you're between 75 and 85 for your lower number, then you're good to go. That's fine. And if you're lower than 75, even better. Athletes are way below 75. Now that upper number it used to be they wanted it to be 125, but they said realistically 135 is a little more accurate. But you really have to know whether you're taking a man's blood pressure, a woman's blood pressure, a child, an old person, because what's normal blood pressure changes depending on the individual. So there isn't really a one good blood pressure. But if somebody asks you, well, what's the best blood pressure? You say, well, it's about 125 over 75, or 135 over 85. So somewhere in that range is a good blood pressure. But if you're over 135, then you're probably looking at some high blood pressure. So you want to be below 135 for your upper reading, and you want to be below 85 for your lower reading. So systolic and diastolic are the two readings that you get. So I forgot to tell you, you can hear right here with your stethoscope, but when you're watching this needle, you can also see it. So as this blood pressure is released here, the air pressure in the cuff is released, you're going to go down 180, 160, 150. And when you get somewhere around 135, 125, you'll actually see the needle start jumping. So it was smoothly going down. All of a sudden it goes tick, 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 tick. And you can actually watch it jump with every pulse, with every beat of your heart. And then when you get around to 75, 85, somewhere over here, then all of a sudden it goes smooth again and you don't see the bump, bump, bump anymore. So smooth, smooth, bump, 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 smooth. So you can see it on the dial, you can hear it through the stethoscope, or if you have a digital one, it'll just read it for you. So the only thing you have to do if you have a digital one is make sure that you don't put the tubing behind the arm, because the artery is right there. there's another YouTube video that they want you to watch right here, and it shows you what your heart rate looks like if you're just resting, you know, just chilling and sitting around, or after you have run up and down the hall. So one of the things that we do when we have you come to lab in person is we have you run up and down the stairs and then come in and take your blood pressure. And you're going to get a definite different heart reading once you've run up and down the stairs a time or two than you are if you're just sitting there at your bench trying to stay awake while your teacher's talking to you. There are some interesting questions that they ask you to kind of make you think about what all you're learning and what it can mean. And here's one of them right here. So they're talking about a pulse deficit, and the apical pulse was that heartbeat you got by using a stethoscope. So you put it up in the antecubital region and you were listening there, and you can get the pulse there. So when I said it was bouncing, bounce, 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 that's your pulse rate. So you can actually count 1, 2, 3, 4, and you can see how many times that the heart is beating. And then we also talked about going down to your radial pulse. Come right up from your thumb and do the radial pulse, and they should be the same. You should have the same beats per minute up when you're up in the bend of your elbow as you do when you're down on your wrist. So it says if it's a difference of more than 4 beats per minute, then you have a physiological problem. Obviously, the blood's not making it down your arm. So they ask a question, well, why can't the radial pulse be greater than the apical pulse? Well, this pulse, the one that the apical pulse is the one you're taking that's closer to the heart. So you can't have more beats down in the wrist than you have above it. So it's just kind of a little something to think about there. Let's see. What physiological problem might a pulse deficit indicate? Well, you're not able to get the blood flow down your arm all the way down to your wrist for some reason. And then there's some math that you guys can do, and I recommend you play around with this. Definitely work these problems. So you want your pulse pressure is the difference between your systolic and diastolic pressure. So we said 125 over 75. You subtract those two. That's what that is, systolic and diastolic. The highest number, the lowest number. And that tells your pulse pressure. That's the highest amount of pressure in your vessels and the lowest amount of pressure in your vessels. All right, and then you can get your mean arterial pressure, and that is your diastolic pressure, DP, plus a third of your pulse pressure. So subtract these two, take a third of it, and add it back to the diastolic pressure. And that is your mean arterial pressure. All right, and then here we have, if you're less than 120, you're gorgeous. That's wonderful. If you're less than 80, you're great. Again, depends on whether you're a man, you're a woman, you're an athlete, you're an old person, you're a little kid. So it can vary, but in general, for most people. So if you're over 139, you're in trouble. You actually have high blood pressure. And if that lower number is above 90, you're in trouble. Make sure that you do your online labs that are in the Connect labs, but don't get frustrated and bogged down. I've had students, they said, I've spent 2 hours trying to get that thing to work and I can't get all the way through it. Each of your labs is only worth 1 point. So if you can do the majority of it, I'll give you your 1 point. So make sure that you understand what the lab is trying to get you to see. Why are we making you do it? What are you learning from it? And that's the important thing. Not that you carry it all the way to completion and do every single step of it, if it's frustrating. So I'm just giving you a heads up on that. And that's it for this lab, week 2.